Hello, this is Dr. Brooke Patterson, and this lecture is on mental status and the neurological system. When we think of the neuro or the nervous system, we can think about both the central and peripheral nervous system, the brain and the various lobes that control a range of bodily functions, blood pressure, pulse, temperature, and emotions. On the left, you can see an example of the dermatomes and how these areas correspond to the area of spinal involvement. With a health history, it is important to ask and document if the patient is experiencing any headaches, history of head injury or injuries, dizziness and or vertigo, weakness or paralysis, sensory changes such as numbness and tingling, syncope or near syncope, seizures and tremors. Using OLCART is key in each of these situations to determine the time of onset, if acute or chronic, and if the issue is an emergency. Headaches have many causes ranging from benign to emergent or life-threatening. For example, subarachnoid hemorrhage could be a situation where a patient may describe the headache as the worst headache they've ever had. This is sometimes referred to as a thunderclap headache. Other causes that are life-threatening include meningitis or mass lesions. Using OLCART helps us tease out which of these headaches are likely benign versus emergent or life-threatening conditions. There are two types of headaches: primary and secondary headaches. I want you to be familiar with the different types of headaches, including migraine, tension, and cluster headaches, and the defining characteristics of each of these. Dizziness and vertigo are very vague and subjective symptoms, but can have many different causes. Again, ranging from benign causes such as inner ear problems to more emergent issues. Weakness is another vague term frequently used to describe how one is feeling. Weakness can imply anything from fatigue to paralysis, so it is important that we ask very specific questions to determine what weakness means to the patient. Another important neurological finding is loss of sensation. Again, we have to ask specific questions to understand the type of sensation that is present and to distinguish between paresthesias, numbness and tingling or pins and needles, diesthesias, stinging and burning, or general nerve pain that is often described as shooting pain or an electric type shock pain. Syncope or near syncope can be caused by a number of different origins. One of the most common causes are blood pressure fluctuations, orthostatic hypotension, and or potential arrhythmias. There are several types of seizures that can involve a loss of consciousness as well. Like migraines, they can sometimes be preceded by an aura or abnormal feelings, thought processes, sensations, or visualizations like floaters or halos, etc. Tremors can also have a variety of causes. They are involuntary movements that may occur with or without neurological manifestations. They may include trembling, shaking, uncontrolled body movements, and or restless legs. Two common types of tremors include resting tremors versus intention tremors. Resting tremors occur when the hands are relaxed and often occur in Parkinson's disease. Intention tremors are involuntary movements during intentional movements. Essential tremors are the most common and are benign, and also occurring with intentional movements. The biggest difference in intention and essential tremors are that intentional tremors are slower with more of a zigzag pattern. Question 1 asks, vertigo is common with all the following except A, inner ear conditions, B, a brainstem tumor, or C, diplopia. The answer is C, diplopia. Diplopia is double vision. Important points of the neuro exam include the patient's mental status, which we will go through in more detail later, speech and orientation. These are things that you can start to know as you are interviewing the patient. You can also simply watch the patient walk into the room, watch their gait, stance, etc. For a more in-depth exam, there are official techniques to evaluate the motor system, such as rapid alternating movements, finger to nose, and heel to shin test. You will also note some overlap with the musculoskeletal system, as a patient's muscle strength and tone can give great insight into a patient's neurological status. For sensory evaluations, there are different ways in your book to evaluate pain, temperature, vibration, light touch, and discrimination. You won't be conducting deep tendon reflexes in this course, but I do want you to know what these are and to just review these and review the scale on the next page. They are elicited by a reflex hammer, and like pulses and edema, they are also rated by intensity and are helpful in evaluating for neurological problems. This is a scale for grading reflexes that are elicited by a reflex hammer. I don't want you to memorize this, but just look over and be familiar with it, noting that the scale ranges from 0 to 4+, and these responses are valuable in neurological evaluations. There are 5 components to a mental status exam. 1, appearance and behavior, 2, speech and language, 3, mood and affect, 4, thought processes and content, and 5, cognitive function, which includes orientation. Orientation includes the following questions: person, place, time, and situation. I would like for you to review the terms that are often used to describe the level of consciousness. These range from alert and fully responsive to coma. The terms to review are alertness, where a patient is looking at you and is responding appropriately. Lethargy or lethargic, when a patient is drowsy and falls asleep easily. Obtunded, when a patient opens their eyes and looks at you and is slow to respond and is somewhat confused. Stupor is when a patient arouses only after painful stimuli, and coma is being in a completely unarousable state. This question asks, the awareness of personal identity, place, and time are referred to as A, level of consciousness, B, perceptions, C, orientation, or D, memory. The answer is C, orientation. Orientation refers to the patient's awareness of their personal identity, where they are, and the time. It requires both memory and attention. For the assessment of the unconscious patient, you would first want to obviously address the ABCs and intervene in an emergent situation. The Glasgow Coma Scale is what we will use to evaluate the level of an unconscious patient. The Glasgow Coma Scale measures the following areas: eye-opening, verbal response, and motor response. It is interpreted on a scale of 3 to 15, with 3 being no response to 15 being fully alert. Patients whose level of consciousness involves drowsiness, but they open their eyes and look at you, respond to questions, and then fall asleep are referred to as A, comatose, B, obtunded, C, stuporous, or D, lethargic. The answer is D, lethargic. Lethargic patients are drowsy, open their eyes, respond to questions, and then fall back to sleep. Obtunded patients open their eyes and look at you but respond slowly and are confused. Stuporous patients are unaware of their surroundings and may be unresponsive to painful stimuli, and comatose patients are unconscious and do not respond to painful stimuli. There are many health promotion and counseling topics for the neurological system, but some popular ones that come to mind are stroke prevention, screening for anxiety, depression, suicide risk, and substance abuse disorders. It is important to screen all adults over the age of 18 for anxiety and/or depression, but also know that sometimes a patient will present with somatic symptoms that don't really sound like depression or anxiety, but after a thorough history, physical exam, and screening, you may uncover these findings. Prompt treatment and/or timely referrals are so important. FAST is an acronym that is often used to help clinicians remember the warning signs of a stroke. This includes facial drooping, arm weakness, speech difficulties, and time to call 911. Beyond FAST, there are also other warning signs that are a little more general in nature. These include sudden numbness or weakness of any extremity or face, sudden confusion or difficulty with understanding, visual difficulties, sudden difficulty with walking, dizziness, level of consciousness or coordination, or a sudden severe headache with no known cause. These also can be symptoms of a TIA, and a prompt quick response is needed as well. Strokes and cardiovascular disease in general have many different modifiable and non-modifiable risk factors. Some of these include a history of hypertension, atrial fib or other arrhythmias, obstructive sleep apnea, smoking, dyslipidemia or coronary artery disease, diabetes, elevated BMI, poor diet and or nutrition, certain medications such as oral contraceptives, a sedentary lifestyle, or alcohol abuse. Personally, I have seen this come down to just genetics as well. So early screening for coronary artery disease and lipids may be warranted for those with a family history of stroke and heart disease, especially those with those findings at a young age. And this concludes our lecture on the neurological system and mental status.